Hello everyone, welcome back to PodBites, where we break down complex medical topics into bite-sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm Adeeba, your host for today's episode, and I'm very pleased to be joined by my dear friend Zainab.
Hey everyone, and thank you Adeeba for the warm welcome. Super excited about today's topic. We're diving into tumors of the small and large intestine, covering everything from polyps to adenocarcinomas, including key risk factors, diagnostic clues, and treatment options. For today's first case, we have a 56-year-old male who presented with rectal bleeding, unintentional weight loss, and intermittent abdominal pain over the past few months. His family history is significant for colon cancer and a first-degree relative. A colonoscopy revealed a large sessile polyp in the sigmoid colon, and biopsy results indicated adenocarcinoma.
That sounds concerning. Let's break down what could be going on here, starting with the basics.
Colorectal cancer is the third most common cause of cancer and the second leading cause of cancer-related deaths worldwide. It primarily affects individuals over the age of 50, with risk factors including a Western diet, obesity, smoking, and a family history of the disease. Most colorectal cancers arise from adenomatous polyps, which are neoplastic growths with dysplastic epithelium.
So essentially, not all polyps are dangerous, but adenomas are the ones to watch out for because they can turn into cancer. Got it.
Yep. Now, let's talk about different types of polyps in a bit more detail because not all of them are equally dangerous. So first up, we have hyperplastic polyps. These are pretty common, especially in older adults, and you'll usually find them in the left colon. They're small, typically less than 5 millimeters, and they don't have any malignant potential, which is a relief. Under the microscope, they have a serrated surface but no dysplasia, so they're generally harmless. Now, the ones we really need to pay attention to are the adenomatous polyps.
Most adenomas are benign though, am I right?
Yeah, you are. However, adenomas gives rise to most colorectal adenocarcinomas. They are dysplastic, and risk factors include smoking, obesity, family history, old age past 50, and a Western diet. These factors lead to diminished apoptosis, persistent cell replication, and failure of cell maturation and differentiation.
Alright, I got it now. What are the different kinds of adenomas?
Now, they come in three main types based on their architecture. You have tubular, villous, and tubulovillous. Tubular adenomas are the most common, and they're usually less aggressive. They're often pedunculated, meaning they have a stalk. Then we have villous adenomas, which are more worrisome. They tend to be sessile, so they lie flat against the colon wall, and they have a shaggy, cauliflower-like surface. They also have a higher risk of becoming cancerous. Tubulovillous adenomas are kind of a mix between the two, with an intermediate risk of malignancy. The key thing about adenomatous polyps is that dysplasia is always present, which is why they're so clinically significant. The risk of invasive carcinoma increases with increasing size, high-grade dysplasia, and villous morphology. Moving on, we have sessile serrated adenomas, which are often found in the right colon. These are a bit tricky because they can look a lot like hyperplastic polyps, but they have malignant potential. The difference is that their serrated architecture extends all the way down to the crypt base, not just at the surface. So they can progress to cancer through something called the Microsatellite instability pathway, due to mutations in MLH1 or BRAF, so they're definitely something to keep an eye on.
Wow, so it sounds like not all polyps are created equal. What about those that come with other conditions?
Great question. That brings us to inflammatory polyps, which are usually seen in conditions like ulcerative colitis and Crohn's disease. These polyps aren't malignant, and they're actually just a result of chronic inflammation. Patients often present with rectal bleeding and mucus discharge, which can definitely be alarming, but that doesn't mean cancer. Then we have both hamartomatous polyps, which have both stromal and epithelial elements and can either occur sporadically or as part of genetic syndromes like Peutz-Jeghers syndrome and juvenile polyposis. On their own, these polyps have a low risk of turning cancerous, but the syndromes they're associated with do carry a higher cancer risk. So even if the polyps themselves aren't that threatening, the bigger picture definitely is.
Got it. So the key is not just the type of polyp, but also the context they appear in. Makes sense. So how do these polyps actually turn into cancer?
Excellent question. So when it comes to how colorectal cancer develops, there are really two main pathways we need to talk about. The first one is the APC beta-catenin pathway, which is sort of the classical route that leads to cancer. This pathway starts with mutations in the APC tumor suppressor gene. Normally, the APC gene keeps cell growth in check, but when it's mutated, it loses control, leading to a buildup of beta-catenin. This protein then moves into the cell nucleus and turns on oncogenes like MYC and cyclin D1, which promote cell proliferation. As if that wasn't bad enough, additional mutations in genes like KRAS and TP53 come into play, pushing things even further down the path to cancer. This whole sequence, from a benign polyp to cancer, is what's known as the adenoma carcinoma sequence. It's actually responsible for about 80% of sporadic cases of colorectal cancer, so it's pretty common.
Interesting. And what is the second pathway?
The second pathway is called the microsatellite instability pathway. This one is a bit different. It involves defects in DNA mismatch repair genes. Think of these genes as the spell checkers for our DNA. When they don't work properly, errors slip through during cell division, leading to mutations, especially in regions called microsatellites. Some of these mutations affect genes that are really important for controlling cell growth and death, like TGF-beta and BAX. This pathway is often seen in patients with Lynch syndrome, which is also known as HNPCC, hereditary non-polyposis colorectal cancer.
That makes sense. So it's like there are two main highways to cancer. One that's more about accumulating mutations step by step, and another that's about letting a lot of small mistakes build up without correcting them. And lifestyle can kind of act like traffic, speeding things up, huh?
Exactly. That's a perfect way to think about it.
That's a lot going on at the cellular level. What are the main symptoms patients present with?
So the symptoms you see really depend on where the tumor is. If it's on the right side of the colon, patients usually have chronic blood loss, which can lead to iron deficiency anemia, fatigue, and weakness, so it's kind of subtle. On the left side, it's more about obstructive symptoms like constipation, cramping, and even blood-streaked stools. And if the tumor is in the rectum, patients might feel like they constantly need to go, which is called tenesmus, along with rectal bleeding.
And how do doctors figure out what's going on?
The go-to test is a colonoscopy. It's really the gold standard because it not only lets doctors see what's happening, but also lets them take biopsies right then and there. For figuring out if the cancer has spread, they'll usually do CT scans. Blood tests for biomarkers like CEA, which is carcinoembryonic antigen, can also give clues, especially if the disease is more advanced. And of course, the final confirmation comes from histopathology, where they look at the tissue under a microscope to check for epithelial dysplasia.
So it sounds like a mix of symptoms, imaging, and lab tests are key to getting a clear picture.
That's right.
That makes sense. So once diagnosed, what are the treatment options?
So when it comes to treatment, it really depends on how far that cancer has spread. For early stage cases, doctors usually go with endoscopic polypectomy or local resection, basically just removing the polyps or the affected area. But if it's more advanced, then we're talking about surgical resection followed by chemo or radiotherapy, especially if it's rectal cancer.
And what are the drugs used in such cases?
The usual chemo drugs include 5-fluorouracil, oxaliplatin, and irinotecan. If the cancer has spread, they might add in targeted therapies like EGFR inhibitors, for example, cetuximab, to help slow things down.
Do patients have a good prognosis generally?
The prognosis really hinges on how deep the cancer has gone and whether it's spread to lymph nodes. If it's caught at stage 1, the 5-year survival rate is over 90%, which is pretty good. But for stage 4, that drops to less than 10%, which is a lot more serious. There are also some potential complications to watch out for. The most common ones are metastasis to the liver, lungs, and bones. However, carcinomas of the anal region usually spare the liver. And then there are post-surgical risks like anastomotic leakage, which can cause all sorts of issues.
All right. And is there anything that we can do to prevent all of this from happening?
As for prevention, keeping things simple is the way to go. A high-fiber diet, regular colonoscopy starting at age 50, or even earlier if you're at high risk, and some studies suggest that aspirin might help because of its COX-2 inhibition effects. So a lot of it comes down to catching things early and making a few lifestyle tweaks.
Prevention is key. Now let's talk about some other conditions and familial syndromes in the GI tract.
Let's consider a 9-year-old boy who presents with painless rectal bleeding. His mother mentions that he has passed mucus in his stool on several occasions. A colonoscopy reveals multiple smooth pedunculated polyps in the rectum.
Let me think. This case is a classic presentation of juvenile polyposis syndrome.
Exactly. Juvenile polyposis is an autosomal dominant syndrome characterized by the presence of multiple hamartomatous polyps in the GI, predominantly in the colon and rectum. While the term juvenile refers to the histological appearance of the polyps rather than the age of onset, most cases do present in children younger than 10 years old.
How do these polyps appear?
These polyps are typically pedunculated with a smooth surface and are often less than 3 centimeters in diameter. On histological examination, they show cystic spaces filled with mucin and inflammatory debris, with a bland glandular epithelium. Juvenile polyps are the most common type of hamartomatous polyps. They can occur sporadically as solitary lesions, which usually have no malignant potential. However, in the context of juvenile polyposis syndrome, where patients present with multiple polyps or a family history, the risk of GI and pancreatic adenocarcinomas is significantly increased. This syndrome can be diagnosed if a patient has more than 5 juvenile polyps in the colorectum, juvenile polyps occurring outside the colon, or any number of juvenile polyps plus a family history of the syndrome.
And what exactly causes this condition?
The underlying pathophysiology often involves mutation in the SMAD4 or BMPR1A gene, which play a crucial role in regulating cell growth and apoptosis. Due to the increased risk of malignancy, patients with juvenile polyposis require regular surveillance colonoscopies, and in some cases, prophylactic colectomy may be considered.
So even though these polyps seem benign at first, the risk of cancer makes regular monitoring essential. Now, let's consider a 22-year-old female who presents with abdominal pain and multiple episodes of small bowel obstruction. On examination, she has dark spots on her lips and oral mucosa. An endoscopy reveals multiple hamartomatous polyps in her small intestine.
Mucocutaneous hamartomas? This case is highly suggestive of Peutz-Jeghers syndrome, which is an autosomal dominant disorder characterized by multiple GI hamartomatous polyps and mucocutaneous hyperpigmentation. The dark spots seen on the lips, oral mucosa, and fingers are classic signs.
Can you tell us more about Peutz-Jeghers syndrome?
Most patients have a mutation in the LKB1 tumor suppressor gene on chromosome 19p13.3. Although the polyps themselves are benign, the syndrome carries a significant risk for various malignancies, including cancers of the colon, pancreas, breast, lung, ovaries, uterus, and testes. Polyps are pedunculated. In other words, they have a stalk, they're lobulated, and most commonly found in the small intestine, but can also occur in the stomach, colon, and less frequently in the bladder and lungs. On a microscopic level, these polyps have a characteristic arborizing network of connective tissue and smooth muscle, which helps pathologists distinguish them from other types of polyps.
Mutations in LKB1. Got it. So even though the polyps are benign, the cancer risk makes this a big deal. Now on to our next case. Imagine a 17-year-old boy who comes in with rectal bleeding and is found to have hundreds of polyps throughout his colon on a colonoscopy. His father also had colon cancer at a young age.
This case fits the profile of familial adenomatous polyposis, or FAP, an autosomal dominant disorder marked by the presence of hundreds to thousands of adenomatous polyps in the colon, often appearing during the teenage years. This condition is caused by mutations in the APC tumor suppressor gene on chromosome 5q2122. The risk of colorectal cancer in these patients is almost 100% if left untreated, with cancers often developing before the age of 30.
Hundreds of polyps and 100% risk of cancer? That's no joke.
Exactly. Prophylactic colectomy is usually recommended to prevent cancer progression.
If I recall correctly, FAP also has some important subtypes. Can you tell us about them?
FAP has notable subtypes, such as Gardner syndrome, which includes extracolonic manifestations like osteomas, epidermal cysts, desmoid tumors, and dental abnormalities. Turcot syndrome, another subtype, combines FAP with a high risk of malignant CNS tumors, particularly medulloblastomas. Pathophysiologically, the loss of APC function leads to the accumulation of beta-catenin, which activates oncogenes like MYC and cyclin D1, promoting uncontrolled cell proliferation. Keep in mind, though, that most FAP cases are familial, but 30 to 50% harbor new mutations.
Alright, now let's consider a 45-year-old woman who's diagnosed with right-sided colon cancer and has a family history of both colon and endometrial cancer. Genetic testing reveals mutations in the MSH2 gene. What is the diagnosis in this case?
So a cluster of cancers. I see. This scenario is highly indicative of Lynch syndrome, also known as hereditary non-polyposis colorectal cancer, or HNPCC. Unlike FAP, Lynch syndrome does not lead to hundreds of polyps, but instead causes a higher risk of colorectal cancer due to inherited mutations in DNA mismatch repair genes like MLH1, MSH2, MSH6, and PMS2.
And what effect do these mutations have on the colon?
These mutations result in microsatellite instability, allowing mutations to accumulate in genes that control cell growth and apoptosis, such as TGF-beta and BAX. Lynch syndrome tends to present at a younger age than sporadic colorectal cancers and is often found in the right colon with mucinous morphology. Patients with this syndrome are also at a higher risk for cancers of the endometrium, stomach, and ovaries, making early detection and genetic counseling essential. In Muir-Torre syndrome, HNPCC patients would have skin manifestations as well.
So with Lynch syndrome, it's more about quality than quantity when it comes to polyps. Got it. Okay, listeners, one more case for today. Let's look at a 35-year-old woman who presents with right lower quadrant pain, mimicking appendicitis. During surgery, the surgeon finds a mass at the tip of the appendix, which pathology later confirms as a carcinoid tumor.
This case illustrates the most common type of appendiceal tumor, a carcinoid tumor, typically found at the distal tip of the appendix and often discovered incidentally.
Now that does not sound very reassuring.
Actually, carcinoid tumors generally have a favorable prognosis as they rarely metastasize. However, the appendix can also harbor other tumors such as conventional adenomas, which can cause obstruction and mimic appendicitis symptoms. More concerning are mucinous neoplasms, which can range from benign mucinous cystadenomas to malignant mucinous cystadenocarcinomas.
And what are some possible complications?
In some cases, these tumors can rupture, leading to a condition called pseudomyxoma peritoni, where mucin fills the peritoneal cavity. This condition can be life-threatening and often requires aggressive surgical intervention. Diagnosing these tumors usually involves imaging studies such as CT scans, which can differentiate between benign and malignant lesions based on the presence of mucin or solid masses.
That's interesting. I didn't realize the appendix could have such a variety of tumors.
We also have relatively common conditions associated with the appendix, like acute appendicitis.
Yes, I know this one. It happens when the appendix becomes inflamed, usually due to an obstruction. This obstruction is often caused by a fecalith, which is basically a hard mass of stool, or less commonly by lymphoid hyperplasia, especially in younger patients. When the appendix gets blocked, bacteria start to multiply, leading to inflammation, swelling, and infection. And if it's not treated quickly, the appendix can actually rupture, causing peritonitis, which is a life-threatening infection of the abdominal cavity.
Yep, good job, Adeeba. The symptoms usually start with vague pain around the belly button or periumbilical pain that gradually shifts to the lower right side, known as McBurney's point. Along with the pain, patients often have nausea, vomiting, and a low-grade fever. One classic sign is something called rebound tenderness, where pressing on the abdomen might not hurt as much, but releasing the pressure causes a sharp pain. For diagnosis, the gold standard is imaging, usually a CT scan for adults or an ultrasound for children and pregnant women. Blood tests often show an elevated white blood count due to the infection.
And how do we manage acute appendicitis?
Treatment almost always involves surgical removal of the appendix, known as an appendectomy, which can be done either open or laparoscopically. In some cases, if the appendix hasn't ruptured, doctors might start with IV antibiotics and monitor the patient closely before surgery. But if there are signs of a rupture, it's straight to the OR because the risk of complications like abscess formation or sepsis is just too high. The prognosis is usually excellent if treated promptly. Most patients recover quickly after surgery, but if it's delayed and the appendix ruptures, the risk of complications goes up significantly. Focal abscesses may also form within the wall, leading to acute suppurative appendicitis, and these may even progress to acute gangrenous appendicitis, which often is followed by rupture and suppurative peritonitis.
So it's really a race against time with appendicitis. No wonder they rush people to surgery as soon as it's diagnosed.
Exactly. Once that appendix bursts, things get a lot more complicated.
All right, listeners, now it's time to put our knowledge into a test. Let's see if you can answer these questions. Question 1. Among tubular, villous, and tubulovillous adenomas, which subtype has the highest risk of becoming cancerous and why?
Villous adenomas have the highest risk of becoming cancerous due to their large surface area and higher degree of dysplasia.
Precisely. Now on to our next question. A woman is diagnosed with right-sided colon cancer and has a family history of endometrial cancer. What is the most likely condition and what genetic mutations are commonly responsible?
Our patient likely has Lynch syndrome, caused by mutations in DNA mismatch repair genes like MLH1, MSH2, and less commonly, MSH6 and PMS2. These mutations lead to microsatellite instability, allowing unchecked accumulation of mutations that promote cancer development.
Let's make the questions a bit more challenging then. A teenager is diagnosed with hundreds of adenomatous polyps throughout his colon. What is the standard management in this case?
Yeah, so this is definitely FAP. The standard management for FAP is prophylactic colectomy because there's nearly 100% risk of developing colorectal cancer if left untreated.
Exactly. Now to our last question for today. A 22-year-old woman presents with abdominal pain and dark spots on her lips and oral mucosa. Endoscopy reveals multiple hamartomatous polyps. Which gene is most commonly linked to this syndrome?
Peutz-Jeghers syndrome is associated with mutations in the LKB1 gene.
Okay, listeners, this brings us to the end of our session. Zainab, can you give us a quick recap of everything we covered today?
All right, so we covered a lot about polyps, adenomas, and different types of tumors in the small and large intestines. Let's break it down quickly. We started with polyps, like hyperplastic polyps, and they're usually harmless and don't turn into cancer. There are also adenomatous polyps, which are ones to watch out for. Adenomas come in different types. Tubular adenomas are the most common and less risky, while villous adenomas are a lot more dangerous. Then there are sessile serrated adenomas, which are tricky because they look like harmless hyperplastic polyps, but actually have a real chance of turning into cancer if they're not removed. We also talked about some special types of polyps, like inflammatory polyps, which show up in conditions like IBD, and hamartomatous polyps, which can either show up on their own or as part of syndromes. Speaking of syndromes, we covered a few in detail. Peutz-Jeghers syndrome is known for those dark spots on the lips and multiple hamartomatous polyps, which comes with a high risk of cancers in other organs like the colon, pancreas, and breast. Juvenile polyposis syndrome involves multiple hamartomatous polyps in the colon and rectum and comes with an increased risk of GI cancers. Familial adenomatous polyposis is the one where you get hundreds to thousands of adenomatous polyps in the colon, usually in your teens. And the risk of cancer is almost 100% if it's not treated. So most patients end up needing a prophylactic colectomy. And lastly, we have Lynch syndrome, HNPCC. It doesn't cause a lot of polyps, but it does significantly increase the risk of colon cancer and others like endometrial and ovarian cancer. This one is linked to defects in DNA mismatch repair genes. Then we moved on to tumors of the appendix, the most common being carcinoid tumors, which are usually pretty harmless. But we also talked about mucinous neoplasms, which if they burst and spill mucus into the abdomen, they can cause a serious condition called pseudomyxoma peritoniae. The main takeaway, not all polyps are created equal, so it's all about figuring out which ones are dangerous and removing them early. That's why regular screening colonoscopies are so important, especially for people with a family history of colon cancer.
Wow, that was a lot of information, but you made it super easy to follow, Zainab. So the key is really catching these polyps early and knowing which ones to worry about.
Exactly, Adeeba. Early detection and prevention can make all the difference.
That's all for today on PodBites. We hope you enjoyed breaking down these cases with us. Make sure to follow us so you don't miss a single episode. Until next time, stay curious and stay healthy.